Assalamu alaikum. Welcome to today's cataract surgery insight into hazy cornea and horizontal chop. I'm Dr. Abdur Rahman Mohammad going to present this surgery. I have made right and left side port with a 1.2 NVR blade. Now I'm staining the anterior capsule with Tryphon blue. I want a good anterior capsule stain because there is a hazy cornea due to prior pterygium surgery. Now I'm washing the Tryphon blue with balanced salt solution. Now I'm placing intercameral OVD to form the AC prior to main port incision. I'm making the main port incision with 2.4 millimeter steel keratome. I have made a two planar incision. Now I'm refilling the anterior chamber with OVD. Now I will commence with the construction of the continuous curvilinear capsulorhexis with a system. I always like to perform capsulorhexis in a tight anterior chamber with pressurized chamber with OVD. In doing this, I can flatten the anterior capsule so that the rhexis will not run out. Whenever the anterior chamber is inertically filled with OVD, the interlenticular pressure and the vitreous pressure pushes the anterior capsule, and this can lead to radialization of the anterior rhexis margin. To prevent this, always refill the anterior chamber with OVD so that the anterior capsule is flat and it has no chance to radialize. It is better to use heavy gel during construction of capsulorhexis. In doing so, I have created a beautiful capsulorhexis of 5.5 millimeter continuous curvilinear capsulorhexis. Now I am performing hydrodissection followed by hydrodelineation. Always remember, during hydrodissection, take out some OVD, then perform hydrodissection. Now I'll commence with the rotation of the nucleus. Since it is a very soft cataract, I've decided to use a ball chopper to perform horizontal chop. Now I'm using a phaco machine called Pharos from Otley. It is a Switzerland machine, and this machine has a phaco tip with a double flared phaco tip. See how I'm beautifully performing horizontal chop of this nucleus. I've created four quadrants by horizontal chop. Now I'm further sub-chopping the quadrants by horizontal chop and emulsifying the quadrants in the anterior chamber at the level of the iris plane. One nuclear fragment has got caught in the angle. Now I'm using OVD to push the quadrant at 12 o'clock position. Now again I'll remove the cortex. Emulsify the quadrant in quadrant mode. Now I'm teasing out the epinucleus shell by vacuum, and with the help of the ball chopper I'm guiding the epinucleus shell in the phaco tip and emulsifying the epinucleus shell. Intermediately I'm giving energy and taking out the epinucleus shell. Now remaining cortex is present in the posterior capsule. I refill the anterior chamber with OVD. Now I will perform coaxial IA to remove the residual cortex. First, remove the cortex from the area where the cornea is clear. Now rotate the coaxial IA handpiece and aspirate the cortex from the subincisional area. Always remember to pull the cortex in a tangential manner so there will be less stress on the zonule. And always remember to face the aspiration port towards you, towards the endothelium. Always see the aspiration port. If you face the aspiration port towards the posterior capsule, you can get PCT. So avoid doing that. Now enlarge the main port to 2.8 prior to IOL implantation. I'm implanting the IOL before I have performed polishing and removing the peripheral residual cortex, because due to hazy view I am implanting the IOL to use as a scaffold for protecting the posterior capsule during removal of the residual cortex. I placed the IOL in the PC bag successfully. Now with the bimanual eye handpiece, I am removing the residual cortex at the periphery and at the area under the corneal opacity. Now I have changed hand and removing the cortex that is trapped at the equator of the bag. Now since the cortex is removed, I'll perform stromal hydration of the side ports, and now remaining part is removal of the OVD. So I'm removing the OVD with bimanual by the coaxial eye handpiece. Now the case is completed. Now perform stromal hydration of the main port, side port, and give intracameral antibiotic injection followed by subconjunctival injection. Thank you, my dear friends. Hope this cataract surgery insight was helpful in developing your surgical skills.